So I'd like to welcome everyone coming to this webinar. I know people are still logging in, but thank you so much for coming to our webinar, which is we're going to be focusing on supporting the wider public health workforce. And the RSPH are committed to supporting the public health workforce, and in particular, the wider public health workforce. And we've been using the second half of this year to gather insight from the wider public health workforce, to do engagement across the sector, to find out what are the key issues impacting on the wider public health workforce, in particular around things like career development and recognition and what needs to happen next. And in a couple of minutes, we'll be moving on to my colleague Indigo, who will be talking through some of the engagement that we've done, some of the insight and the key findings from this engagement. Then we'll have about 45 minutes for a panel discussion, including answering some of the questions in the Q&A box, which people should be able to see. The webinar will end at around 2 p.m. Cameras should be off for people watching. If you look down the bottom, there's a Q&A function. So if you've got any questions, just pop them in there and we'll do our best to get through them. And we'll put up links to various sections of the RSPH website and contact details if you wanted to carry this conversation on with us. So I'll do some short introductions to the panel. So we've got Linda Hindle, who's the Deputy Chief Allied Health Profession Officer for England. We've got Nazreen Iqbal, who is the Health Inequalities Lead for the Integrated Stroke Delivery Network, Yorkshire and Humber. We've got Dr. Chloe Selwood, who's the Deputy Head Emergency Preparedness, Resilience and Response for NHS England, London. And we've also got William Roberts, who's the CEO of the Royal Society for Public Health. So I will hand over to Indigo now.
Thanks, Phil. So here we have just a quick introduction to our work. So we've got in our 5-year strategy, we were committed to supporting the public health workforce with a focus on the wider public health workforce. And we also have a working definition of the wider public health workforce, which we are still in the process of developing. But at the moment, we're defining it as any individual or professional who is not a specialist or practitioner in public health, but has the opportunity or ability to positively impact public health and well-being through their work. And we also have our mission statement here, which is that by 2035, there'll be a clearly defined wider public health workforce that has accessible professional pathways and standards to support career development, help secure better paid work, and demonstrate contribution to large-scale health prevention, protection, and improvement. Anyone working within the wider public health workforce should be able to be recognised as a person with public health skills, to understand the routes they have to develop their skill, competency, and career, and recognise the impact they can have on public health and well-being. And you can find our full mission statement on our website. So in our survey, we gathered the views of members of the wider public health workforce. And the survey was open from July to October 2023. And after cleaning the data, we had a total of 391 responses. 63% of our respondents were female, and most responses came from England, although we also had 16% from Wales, 8% from Scotland, and 2.4% from Northern Ireland. We ask about what public health function they do, their career development, what challenges they face, and what support they need. And we also had other engagement directly with organisations that represent the wider public health workforce, as well as hosting a roundtable in September with leaders of the wider public health workforce from across the sector. In this chart, it shows the range of professions who responded to our survey. Some have been grouped together, such as allied health professionals, just to make the list a bit shorter. And as you can see, allied health professionals were one of the groups that we got the most responses from, although we also had a range of other professionals such as environmental health, pest control, emergency services, teachers and planners. And we also had another text box if people wanted to fill out their own occupations. So some of the most frequent responses from there were health and wellbeing coach, health visitor, and different types of nurses. Respondents worked across a range of settings, mostly at community level and service provision within a setting. And here you can see that the NHS and community were where most of our respondents worked, but there was also a significant number working in local government and council, higher education, and the third and private sector. 48% of our respondents entered their role after doing a degree, and 29% entered through career opportunity. 13% of our respondents said that it entered in another way, and many of these specified that that was through doing an online course or module of some description. We asked respondents how they support public health within their role, and you can see from the first chart here that respondents engaged directly with members of the community. So 38% said on a daily basis, and a further 20% said 2 to 3 times a week. And the second chart here asks how often they considered the impact on public health when making decisions. And you can see here quite positively that just under 50% said that they do this on a daily basis, and a further 15% said 2 to 3 times a week. In both of these charts, the orange section there, which is occasionally, is also quite noticeable, and that's probably, we suspect that that's because of the range of different occupations that filled the survey out. Other responses to this question were encouraging vaccine uptake, data analysis, access to green spaces, and health inequalities. And we asked respondents about what best practice examples they had. I won't read through each of these quotes, but just to give you a bit of a taste of the responses we got. There was a lot of different examples of public health training and assessment tools. And we can also see from this quote from a pharmacist, the range of public health services that they were offering at their pharmacy, and a quote from a teacher talking about how they were offering additional cooking and lifestyle classes to promote healthy living in some of the young adults that they were working with. We asked respondents what challenges do they face in their role, and respondents identified that their biggest challenges were their organisation or employer does not have enough funding, their organisation or employer is understaffed, or they feel that they are overworked or their workload is unmanageable. 38% of respondents said that they were not being paid enough to meet their basic needs, and 50% agreed that their organisation has a clear vision for how it can best support public health, although 33% disagreed with this statement. This could indicate that some organisations have a clear vision, but they don't necessarily have the funding or staff at the moment to carry that out. Most respondents from across all 4 nations agreed that these challenges have increased in the last 3 years. And when we asked respondents why, many said because of the repercussions of COVID, both in terms of the pressure that the COVID pandemic had on systems, but also in terms of long-lasting physical or mental health conditions relating to the COVID pandemic and lockdown itself. Also mentioned was misinformation on social media, funding and lack of investment in public health, the cost of living crisis, and health inequalities. And about 70% said that their public health role had increased in the last 3 years. Reasons for this were similar and focused on there being more awareness of public health, that COVID had highlighted, and also COVID had highlighted and exacerbated health inequalities. And that more awareness of public health was both from the public, but also from professionals themselves. Nearly 80% of respondents agreed or strongly agreed that the people they support in their role were feeling the impacts of financial pressures. Here we asked respondents what support they want, and we can see that the top response here was increased resource and funding to public health systems, which aligns with what we've heard so far from the survey and our engagement work. Other responses were more support for career progression by offering training and development opportunities, more recognition of the wider public health workforce at national and regional level, which again came out in our engagement work, and creating a nationally recognised career progression pathway into specialist public health roles. And finally, increased support for health and wellbeing. 9 out of 10 respondents agreed that committing to a long-term plan to provide better support to the wider public health workforce should be a government priority. And we found out from our engagement that it may be easier for some working in the wider public health workforce to understand their role in public health when it's framed as tackling health inequalities. We also note the wider public health workforce want to support in tackling inequalities, and many members of the wider public health workforce are already doing this in their roles. Our next steps. In January, we're going to be launching a report that will look at these survey findings in more depth, but also we will suggest a number of recommendations. And there's several links here to different sources on our website, which we'll put up again at the end and probably in the chat. But if you have any questions about the survey, you can get in touch with us with this email, policy@rsph.org.uk.
Brilliant. Thanks so much, Indigo. And there's two things that stand out for me from this survey is, firstly, how much I've learned about the topic and what a great response we've had from the wider public health workforce as well. And one of those slides in particular, which was about how much the wider public health workforce think of public health in their daily work, that was really great to see. So lots to reflect on from those slides. So let's get going with the discussion. And I've got a couple of questions to kind of start things rolling. And perhaps perhaps when each of the panelists answers this first question, they could just introduce who they are. So could panelists introduce themselves and talk a little bit about how they got into public health, and perhaps more specifically, their role as part of the wider public health workforce? Nazreen, I wondered if you could go first answering that question.
Hi everyone. Yeah, I'm Nazreen Iqbal. I work for West Yorkshire Integrated Care Board. Currently, I'm working as a health inequalities lead within the Integrated Stroke Delivery Network. My sort of journey into how I got into public health. At university, they obviously encourage you to do work experience, and I was a volunteer at a Citizen Advice Bureau. And from there, I graduated, and that's pretty much what I'd be doing, and doing some sort of call centre work, and got a job working at an advice centre for young people. And very different from doing benefit advice to giving sexual health advice and giving out condoms to young people. So real eye-opening time for me. But that sexual health and introduction into young people's mental health really, I think, was the starter for me in terms of my public health work. From then, like most people have said within your survey, I kind of went from working as a young people's advice worker to getting a job in a teenage pregnancy grant-based organisation for the local authority, and then progressed from there. I managed a children's childhood obesity service, so it wasn't a planned route. I just kind of worked for jobs that motivated me, and for some reason I always went for public health kind of related jobs. So that's kind of my sort of broad-based history really in terms of public health. So I've done lots of different roles.
Right, thanks, Nazreen. Chloe, same question.
Thanks, Phil. Good afternoon, everybody. So I'm Chloe. I am the Deputy Head of Emergency Preparedness, Resilience and Response at NHS England in London. I got into an emergency planning through quite a circuitous route. And emergency planning is one of those wider public health areas. I think it's really important that we're seen in this environment and in this part of the workforce. My background, I'm a PhD plant biochemist, and I had an interest when I was studying about public accessibility to science and really making science accessible to the public and sharing the kind of the joy and the interest and the potential for science. So my first role back in 2001, I joined the Public Health Laboratory Service, so I think 4 iterations ago of UKHSA, and I was Scientific Secretary out there supporting about 12 different advisory committees to the government. One of those was flu, and that was my start of my journey into emergency planning. and I co-established the Pandemic Flu Office in what had then become the Health Protection Agency, and worked there with Jonathan Van Tam for a few years. So did lots of work on national policy and guidance, and kind of the overarching stuff that provides the structure behind our public health responses and works across all of public health workforces in the specifics around pandemic flu and avian flu. I then moved into the NHS to take all of that policy and guidance knowledge that I had and try and do something operational and make policy meaningful for patients and meaningful for staff. So I joined what was the Strategic Health Authority in London. I think I've been through 4 different reorganisations of the NHS, but essentially still here, still doing emergency planning, still with a focus on pandemics, but pretty much anything that we can do to prepare for, respond to, and recover from emergencies that happen in the capital. And that's anything from pre-planned events to major incidents to disasters, obviously COVID. My main passion now, though, what I've really got interested in and what I'm really involved in actively since COVID is this aspect of health inequalities and disproportionality. And London's an incredibly diverse city, and I'm really, really keen that we make sure our plans consider all Londoners, not just the white, middle class, middle-aged, English language native speakers. So that's where I really see the benefit of the wider public health workforce across everything that we do in emergency planning. Thanks, Phil.
Brilliant. Thanks, Chloe. So perhaps if we do Linda, then William.
Thanks, Phil, and hi, everyone. So my name's Linda Hindle, and I work for the Office for Health Improvement and Disparities, previously Public Health England, as the Deputy Chief Allied Health Professions Officer and the National Engagement Lead for Police, Fire and Ambulance Services. So my role really is to increase the profile, contribution, capability of emergency services and allied health professionals in public health. But how I got into public health was, I suppose, like everyone else, through a bit of a squiggly route, so to speak. So I'm a dietitian by background, and I think very early in my career I realised I didn't want to work in a hospital. I wanted to work in the community, and so early on my the roles that I went for were things like cardiovascular disease prevention, obesity management and prevention. And I think, like a lot of allied health professionals who come into public health, I tended to just get involved in different groups and committees and networks that were focused around public health and health improvement. And that's kind of what I suppose led me into the right spaces to eventually end up in Birmingham City Council's public health team, and then in Public Health England.
Thanks, Linda.
If I do last one, then Phil. So,
Yeah.
So I'm William. I'm Chief Executive here at the Royal Society for Public Health. I got myself into public health and then out of public health, I guess. So I started off as a clinician. I'm a nurse, and I'm a nurse in infectious and tropical diseases, amongst other things. And so I kind of wanted to have a career in public health. I specialised very early on in that space. I then went on to run a tuberculosis network in London. Did my public health masters, and then found it incredibly hard to go to the next step. So it was really, really difficult to then become a public health director if you weren't going through the standard training route or you weren't a doctor. So I left public health for a while, kind of never really left it because my career has been a lot about inequalities. And I found ways to stay involved in public health, including being a trustee on Europe's largest HIV and sexual health charity, Terence Higgins Trust. So I've sort of held my role in public health, but I went off to be a strategy director because it was a much clearer and easier role to get into positions where you could try to influence policy making. I guess what was frustrating about that job was you didn't really make much of a difference, if I'm honest. You wrote lots of really good plans, but nobody then ever enacted them. So the opportunity to then come back to public health here at the Royal Society has been something for me that's a joy. And I guess to answer your question about what do I think are kind of, you know, the role of the wider public health workforce, we see ourselves very much as the home of that group of people. I think if you look at the range of people we've got, not just on this panel, but also the people who've dialed in and are watching us now, I think it really talks about the range of different careers. And I guess building for some of the stuff we want to talk about is, I love the fact that there's this brilliant group of people that every day I get to work with, but come from such diverse and different backgrounds. And I think that's the strength of it, but that's also one of the big challenges we've got to address, Phil. So back to you.
William, so a question that's open for the panel now. So you've all had various routes into public health. You've kind of all gone from A to Z and roundabout in lots of different ways. So thinking about the skills and the kind of experience and qualifications that we need, how can we make sure that the skills and expertise of the wider public health workforce are recognised as transferable by the individual, but also by employers and the system? Quite a big question, but just we've heard a lot through our engagement that people have skills or they want to develop skills through qualifications, but how can we make sure that works in this really diverse system? Free just to kind of chip in and start answering. Nazreen.
Hi, Phil. I've got thoughts on this because I've very similar to Will, kind of wanted to get into public health, did my masters and really struggled. Before I got the masters, I was going for public health jobs and colleagues were saying, oh, you know, you did a really good interview, but you haven't got the masters. I then got the masters and then it was you know, public health, unfortunately having changes, going from the council to going from NHS to local authority, and they were having a transition. There weren't very many jobs coming up at that time, just as I'd finished my masters. So I feel like I've gone through this and I a bit like William decided to then just pursue NHS roles. So like I did a service manager role managing a primary care dental service. Where
perhaps while Nazreen might have been disconnected before she comes, well, so we can wait until she comes back. Chloe, Linda, or William. Oh, sorry, Nazreen, you cut off for a second. Chloe, William, or Linda, did you want to start an answer on that question?
Yeah, I'm happy to come in. Oh, sorry, Chloe. Do you want to go first? Okay. Yeah, so I mean, from my point of view, I kind of agree with the points that that Nazreen was making, that because there's not a clear route into public health unless you're going on to become a specialist in public health or part of the core public health workforce, it can be really difficult for somebody who's interested in the subject to know what qualifications do I need to do, what experience do I need, and what are the roles that I could eventually go for. And I suppose to some extent we're almost kind of creating a future that's not there yet, aren't we, in terms of kind of this kind of big army of people who are contributing to public health. So what I think is needed is kind of a consistent agreement about what are the core skills needed for anybody who's going to say they've got any experience in public health and prevention, obviously at different levels, but then something that's kind of more specific, so that say, for example, a dietitian could say, well, you know, I want to specialize in public health, but only in the context of my role. So I don't need to know all about health protection and lots of other aspects of public health. I need to know about the things that are going to be relevant to my job. And that would be the same if you were a physiotherapist or a paramedic. It would be different things that you might need in order to kind of do public health well within your job. But you could still do that to a high level, but within that much narrower scope. So I think we need that kind of core that everybody needs in terms of an awareness, and then an ability to kind of have more of a modular approach, but in a way that's recognised by all employers.
Thank you, Linda. Nazreen, sorry, I know you got cut off. Was there anything else you wanted to add?
Yes, yeah, I just wanted to kind of share where I was at. So, excuse me. So I kind of gotten into the NHS and did sort of service manager roles. But what I've learned along the way is to kind of build your skills in terms of your experience. So I've got sort of dental experience. I've got a beat childhood obesity, the sexual health. I'm now working in stroke. So that experience of different avenues of different fields was really important. But I think just in the interim, if people are on the call and looking what to do, but also look at I follow a lot of people on Twitter, on social media, on LinkedIn, and you know, if people are doing jobs that you think actually that's a really interesting job, I'd like to do that, look at their sort of LinkedIn profile. What have they done that maybe you could do? And build your own like toolbox, so to speak. So like one of the things I hadn't done, but I know is a really good thing to have on your CV, is doing a health needs assessment. So I've had the opportunity to do that now, and I've kind of grabbed it with both hands. So again, that's something that's added to my toolbox. So those are just some practical things I think people could do whilst we're sort of looking at creating something within the Royal Society of Public Health. But I also think joining this society is really good, because you know, it's been so brilliant for me personally to hear from colleagues and to join this network, because you know, I feel heard, because not a lot of people outside of public health, or people who are interested in health inequalities, they don't understand the challenges that we have to try to get the jobs that we want. So having this space and having colleagues who understand is absolutely you know, incremental and really supportive.
Brilliant. Thanks, Nasreen. And Chloe, what about yourself? What are your thoughts?
Thanks, Phil. So just really building on Linda's points and Nasreen's points, I think there's something about recognising where we as the wider public health force fit within the bigger picture, and how we've already heard how we kind of integrate into everything. We work with each other, we work with different organisations. Linda listed many that she works with. We've got that really wide reach, that really wide network, and networks are incredibly powerful. So I think making use of those networks and using those in the same way that Nasreen identified with looking on LinkedIn and profiles and things, I think can be incredibly helpful. I think as well, it's identifying and being able to talk about where we add value and what benefits we bring as a wider public health workforce. For ages, I felt really far away from patients and really struggled to see the benefit of my writing a strategic plan. And it was only through talking with other people that I was able to then share that and really understand kind of where my value add was and what the benefit was. And that leads me to my third point, which I think is for us, whenever we're talking, is to be really emphasizing the benefit that we bring to patients and the public. I think we all know that, but if we can't articulate that, if we don't have the communication skills and the passion and the use of our networks to kind of do a bit of self-promotion to promote to our employers and to future employers, then I think we're doing ourselves a disservice. And maybe that's in the same way that Linda identified potentially some core skills. Maybe again, that's something we could do as a society around how we support each other in those areas. But I think we're our own best advocates. We can advocate for our own skills, but we need to know what those skills are as well. So I think it's kind of a two-pronged attack, a two-pronged approach.
Thanks, Chloe. William, did you want to come in?
So I just see three very brief things on this. I think everything that the other panelists said is absolutely spot on. I think firstly, when you've got such a wide variety of people, you've got to recognise and respect the fact that they're slightly different, but also that they're offering something really, really powerful. And so I think firstly, that recognition that these roles exist, that these people exist, and that they're out there doing a great job is really important. And I know the panelists have talked about that. I think the second thing is about having a level of consistency and transferability of qualifications. So one of the things that's historically happened, I think, is that people have gone to develop things in-house and do things to the cheapest possible way, as budgets get squeezed. And actually, one of the things that would be really amazing is if people could start to really build consistent and transferable things, so that if you get trained to a certain level, so Chloe knows this from the work she does in emergency planning, you have to have a certain level of training before you become an emergency planner. And what's really good about that is that wherever you go in the world, you know that person is trained to that level and they're competent and that their skills are transferable. I think what we then need to do, once you've got that level of transferability, is we need to close those gaps. So, there've been a few questions on here about in chat and in so far in our discussion about what do we do about this issue when you get to these gaps in the system? So the gap between when you first come into public health and then trying to get yourself more established, the bit where you want to become a bit more expert, the bit when you want to perhaps go onto the register. We need to find ways to make those gaps smaller. So some of the work we're doing is about making those pathways clearer, but also where we see there's a big gap in the educational landscape. So, for example, it's great if you want to be a really high-level emergency planner, but there's nothing to get you into that at the moment. So, if you get into it, it's a bit of luck, really, or perhaps because somebody spots something, but it's not because there's a clear career progression. So I think there's something really important in that about closing those gaps. And then I know Woody's asked a question in chat, which kind of think relates to this, which is, there's lots of different bodies in this space. It's not just us at RSPH. There's also, you know, the Faculty of Public Health, there's the UK Public Health Register, there's OHID, there's UKHSA. And I think the way we're starting to work together as a system is really important, because it's about us helping each other understand the different bits of need. Right now, there isn't a national needs assessment that says how many different jobs do we need in each type in public health. But actually, part of what I think we need to start to do through this work is to articulate that much better, so we can both match supply to demand. Because at the moment, we see there's a huge opportunity in terms of lots of supply out there. We also see there's a huge opportunity in lots of demand out there, but those two things aren't quite gelling at the moment. And so how do we get those to be more consistently linked to one another?
Do the panelists want to come back to any of William's points there? Great. Well, there's a couple of questions in the Q&A about this, and it's come up from the discussion now. But during our engagement, we've heard from the wider public health workforce about a lack of recognition. I know, Chloe, you just talked about the wider public health workforce being their own best advocate. What do you think we can do collectively to increase the recognition of the wider public health workforce, and especially when we think about the work that they do, the communities that they work with, the inequalities that they're helping to tackle? Again, this is for kind of any panelist to come in and start talking to.
So I'm happy to come in on that. I think there's a role for what you might call the core public health workforce here, in terms of talking more about the importance of the wider public health workforce and involving people from across that wider public health workforce in their work, in their planning, in their thinking, and in their solutions. Because and this is not a criticism really of people saying local authority public health teams, because I know the teams are really small. And when I was in Birmingham City Council, we didn't spend perhaps as much time as we might have done talking to people in the wider public health workforce. I think because we were so focused on what we'd got to do. But I think it's like in any system, when you're trying to get a job done, sometimes you can just get your head down to try and get it done. Whereas if you kind of could raise your head a little bit and think about who else can help with all of this, there's a lot of people there who would see it as part of their role, and you know, we go further together, don't we? So I think there's a real opportunity for the core public health workforce to open their doors to us and kind of big up really the role of the wider public health workforce. But I suppose the other thing is, you know, everybody likes to have a bit of that badge, the accreditation, the recognition, don't they? And I suppose that's another way that we can increase recognition, by providing some way of people having the badge or the banner that says, you know, I've got these skills. And that would be from my point of view.
Thanks, Linda. And actually, during Public Health Workforce Week, we put a blog out written by Greg Fell, the president of the ADPH, who wrote exactly about how, from a local authority perspective, how important the wider public health workforce are at kind of building up a system so that you can deliver public health, you can deliver it in the long term, and you can start thinking about inequalities. So there's definitely people out there who are thinking about the wider public health workforce at the moment. Any of the other panelists, did you want to come in on that question? Nazreen, you're unmuted.
Yeah, hi Phil. Yeah, just to build on from Linda's point, as she was talking, I'm just thinking, for me, my sort of, you know, I've been using social media a little bit more with regards to sort of just employment opportunities and progression, and I really felt your visibility as a you know, your sort of society on your LinkedIn and the whole wider workforce survey and the engagements and the blogs, and that really got my interest. So I think there's something about us being visible, not just in the social media sphere, but also wider as a network, but also showcasing and celebrating where the wider workforce of public health, where we do add value, linking on to Chloe's point, where are we adding value? Where is it that teacher is adding? So you've got teachers, you've got pharmacists, where are they adding value to the public health and health inequalities agenda, and how can we demonstrate that and show that within this society? And and take that to people that are going to be interested and listen. So I think there's something about the recognition. You know, me getting this opportunity today has been brilliant, but I think there'll be lots of other people who've got lots of other skills who are part of this society, and how can we sort of really utilize that and support them. And also, finally, I think a community of practice where we also learn from each other. So one of the successes I feel as I've had over the last year is NHS Futures page on population health management. Or I'm working on palliative end of life care, I'm working on stroke. There's NHS Futures pages have been really helpful, where I could ask the question, and colleagues in London have done similar sort of work. There's no point in the economic crisis that we're in, a cost of living crisis, where, you know, resources are really tight. We've got a financial envelope that's constantly being squeezed. Can we learn from other colleagues, and can we learn from within our society as well? I'm sure there's lots of learning to be had.
Thanks, Nazreen. Chloe.
Thank you. I think this is a really interesting area about that kind of recognition and promotion and wider awareness raising. I guess with my academic hat and my scientist background on, I always think about publications, and absolutely recognise peer-reviewed publications aren't everybody's bag. They can be really, really difficult, really long-winded, but there's so many other ways to get your message out there. Just LinkedIn, as Nazreen's already mentioned, there's blogs, which you mentioned, there's magazine articles, all of that sort of thing. And we've managed to publish some quite interesting stuff on diversity in the emergency planning population in the NHS through different routes, using those kinds of opportunities. So there's something around using the kind of the media, and not just social media, to our own advantages, I guess. I really like the point about how we can use kind of not just the core public health, but wider partners and colleagues to our advantage. And I think that's something that would really benefit from a bit more thinking about. I mentioned networks at the beginning. Because we're wider public health workforce, we've got hugely diverse networks, all sorts of people we could tap into. When I think about the people I work with in emergency planning, it ranges from chief executives to fire officers to all sorts. So I think there's something there as well we could be working with. And just to finish, I really like the point Nazreen made about not kind of reinventing the wheel. So there's got to be some stuff that I know it's there that RSPH has done previously, but perhaps we could reinvigorate and reboot and revitalize and use again. But this as a starting point today is brilliant. I think just having the opportunity to hear from colleagues and the questions that are coming in and the comments are amazing. So thank you.
Great. And before William comes in, there was something that struck me, Nazreen and Chloe, that you said about a month ago, we had a round table with some of the wider public health workforce sector, and it was someone from the British Institute for Cleaning Science said something along the lines of, you know, cleaning and hygiene operatives can offer so much, and they know what they can do. So there's something in there about that sector talking to the nursing sector about what could they do that mean they're delivering public health, and nurses are able to go kind of use their time wisely to deliver other types of care. William, did you have anything to come in on?
So I think the only thing that everybody else hasn't said that I think is just worth touching on is that often the people we're dealing with are coming from quite broad backgrounds. So, you know, these aren't people necessarily who are a long way away from the health inequalities they experience. So it's not surprising that in our survey they felt that they had a real role in reducing health inequalities, because often that's the community they live in, it's the place they come from, and it's the role they're doing. And so I do think there's something really interesting about how we demystify public health a little bit, and how we can use the opportunity of both. There's something really good about potentially using this route as a way to get lived experience into the public health space, so that people can actually understand what's really needed on the ground as opposed to in the boardroom. And then secondly, also using this as a way to help people to lift themselves out of poverty. You know, we've heard from a huge number of people who come through our system, it's often the first, you know, the education they do with us is often the first thing they've ever done post 16. You know, in education, and that's quite an opportunity really to really give people access into it. And so, you know, it's really important we create those pathways, but it's also really important we go out and very intentionally think about who we should be trying to recruit, and then give really easy entrance into this system. Because I think, you know, we're the lucky ones, if you like, who've managed to find our way in here. But there's a whole load of people out there who really feel passionate about health inequalities and tackling the wider terms of health that we haven't yet touched on. You know, I mean, I could talk about the work we could do with housing. I could talk about the work we could do with sanitation, cleaning, pest control. We really haven't started to tap into those resources fully yet. But I mean, there's so much we could talk about on this one.
There's, building on that, there's a couple of questions that come in about inequalities and about how the wider public health workforce perhaps don't necessarily recognise that they're doing health inequalities. Is there anything that the panel got any thoughts on how we can either kind of promote the inequalities work that the wider public health workforce are doing, or embed it more in their work? Linda, I can see you nodding.
Yeah, no, I think this is such an important point, and I think it was probably one of the things that resulted from the pandemic, wasn't it? That increased awareness, just generally, of health inequalities amongst the public as well as amongst professionals. And I've certainly seen with allied health professionals that there's maybe kind of a subset of allied health professionals who absolutely got public health prevention. But we didn't necessarily bring everyone along the journey. But then health inequalities is another angle that's brought, I suppose, another tranche of people who think, well, I can absolutely see where my role fits into reducing health inequalities. And so it becomes more relevant to their role. And to throw another one in, I think environmental sustainability is another kind of hook, really, that brings people into this space, because they might not see the benefit of public health and prevention in the context of their role in its own right, but if they can see that actually I'm really passionate about protecting the planet and providing more sustainable healthcare, that means preventing people needing complex healthcare. Therefore, it's prevention. Therefore, it's public health. So, just I think whatever kind of speaks to the individual person as to their kind of value and driver, it all comes back really to the same sort of actions that we would be hoping people would take as part of their role. So I think it's really important, and I think from a health inequalities point of view, it's one of those kind of I suppose any type of inequality, it can feel so big, can't it? And it's easy as an individual practitioner to think, oh, it's the government that needs to do something, or it's the local authority, or it's somebody else. Whereas I think if we can break down health inequalities into those inequalities in access, experience of care, as well as outcomes of care, it makes it then more relevant, and it's easier for every individual to see, well, these are the things that I can do within my role that are going to make a difference, and then those all become cumulative, don't they?
Yeah. Now, Nazreen, I think you wanted to come in.
Yeah, and just picking up, I totally agree with everything that Linda's just said there. I just wanted to kind of share a little bit about I've been working on this stroke health needs assessment recently, and one of the things I've not had to do, I've wanted to do, was to speak to the workforce that work in stroke about what do they think that they can do, or where do they think the gaps are around health inequalities within their patients that they see that have had a stroke, or their carers. And I was thinking about it. I thought, actually, maybe, do people really know what health inequalities are? So I did a slide deck and kind of explained what's health inequalities, unfair, avoidable, differences between different population groups. You know, what are the sort of protected characteristic groups? What are the inclusion groups? And then talked about digital exclusion. And I had a couple of people before that slide deck who said to me, oh, I don't know why I'm here. I don't know much about health inequalities. I'm a dietitian. Does that affect my role? But by the end of it, I had to say, oh, I'm sorry, we've run out of time. Because actually, once you explain to them and you explain to people exactly what Linda's saying, everybody's got a role, I think, to address health inequalities within the workplace, absolutely. But I think what we need to do is we need to empower people to be able to think, actually, you know what, I can do something. And within that, we need to work with the managers to say, actually, it's okay if your staff make this decision, because actually it's going to be a patient benefit, because otherwise this patient would be excluded. So I just wanted to share that.
Thanks, Nazreen. Chloe.
Thank you. So again, I guess a little anecdote. Building on our experiences from COVID, when we really recognised how disproportionate the impact had been across populations, We've been re-looking at our emergency plans and our arrangements just with a different lens, and there's kind of a view that disasters are colour blind, they're person blind. They're absolutely not. Different populations, different groups of people are affected differently depending on what the incident is, where it is, where they are in their life at the time. And we really realised that we'd be taking two kind of a single path when we needed to take quite a diverse and multiple paths to make sure our plans considered everybody. And I think what we initially struggled with was the whole concept of doing a formal equality impact assessment on our plans and looking at that sort of thing. But what we're really finding beneficial is to have the conversations around the populations, around our communities, involving people where we can who represent different groups, so we can really understand what matters to them. And we're really at the beginning of the journey with this in our plans, and we've got so much further to go. But I think having the conversations and thinking about this, we're effectively making it second nature or first nature, really, that we don't have to make a point to consider health inequalities. We are considering them by default because we are making a plan for the people of London, and London is multi-diverse and multi-populations. So I think, building on everything and echoing Linda's and Nasreen's points, there's so much we can be doing about this, and it's just making those small steps count.
Thanks, Chloe. William, did you have anything to say on kind of a practical and solutions perspective?
Not massively more. I think there is a role here as well at a national level, that I think there's something about understanding that a healthy, happy population is a productive one that creates prosperity for your country. And I think there's something about thinking about what should the role of government be, but also what should the role of national bodies be, and trying to build into their requirements some level of understanding of not just the health inequalities, but also consistency and high quality into the workforce. Because we know that everyone we talk to tells us they want to be really trained well, they want to have high quality qualifications, they want to be recognised, but you have to also have a pull factor for that hugely pushes on the individual to make that change. I think what we'd encourage anybody who's in any sort of national role to do is to really understand the value of signalling, mandating, pushing, or even valuing something which creates a stronger and more effective workforce. Because if you do that, it creates a huge push factor for employers to then value their staff more. And I think we underestimate sometimes how much signalling those things can actually have a powerful impact on the system. So whilst it's great that there's those individuals out there that love doing this, that value it, that want to be recognised, we also need some of those governments and national bodies to really also push through saying, we value you as well, and we value this, and employers, you should value this. Because from a financial, economic, productivity argument, all of this stacks up and makes sense. We could have a healthier, more prosperous workforce, but somebody's got to say that matters, and that can't just be about the individual having to do that.
Right, and there's lots of comments coming in, reflecting people's enthusiasm for wider public health workforce. So refuse people having signposting information on vehicles, how they're doing lots of work to kind of create a bridge between staff wellbeing, community wellbeing, and someone talking about the importance of inequalities and the environment. And that's all amazing to hear. I guess my question that comes to me is about, going back to training and going back to career support. What are the barriers to accessing that kind of training and career support? And perhaps, I know we're starting to run out of time, what are the panelists' kind of solutions to that? Chloe.
Start this one. So I'm going to start with maybe a solution rather than the barriers, so start positive. I know I've really benefited from opportunities to shadow people and from receiving mentoring, and not necessarily people who are more senior in my direct kind of line of profession. So from having conversations as an aside with someone at a meeting or wherever, and just going, oh, sounds really interesting. Can I come and spend some time with you? So I'd absolutely recommend that. It's not necessarily formal training. It's not necessarily something you can put on your CV, but you're building your network. They know you're interested. They might hear of something that they might let you know about. So in that way, I think it supports your career as well as broadening your knowledge and your information. So absolutely recommend shadowing, mentoring, formal, informal, all of those options.
That's right.
Hi, Phil. Yeah, so just to add on, I think some of my other things would be the power of networks. I think Chloe mentioned it earlier, but I took a career break, and since coming back, I couldn't believe the amount of networks that were available to me and have been so helpful. So if anybody's on the call from a South Asian background, there's an UPNAR network, which basically means hours, and that's a national network of South Asian colleagues across the country, and it's just amazing and just wonderful colleagues who you can get mentoring from, you can get shadowing, and there'll be local people but national as well. So and you just get invited to loads of different things, and there's a WhatsApp group that's been really helpful. There's also NHS Muslim Women's Network, that's again a national network, which I've personally, as a woman of South Asian, a woman of colour, just didn't see before my career break many women from a colour background in leadership positions in the NHS, but having come back, and obviously now we're in a virtual world on MS Teams and using social media, that's much more visible, and it just really encourages you to break that glass ceiling. So those opportunities are available. I'd also say, you know, this webinars like this and other webinars that are available. So before, conferences would cost a lot of money in hotel accommodation. So conferences and webinars are free. So access them and make sure you collate a list of them and keep them on your CV, so when you're applying for jobs, you've got them. So it kind of gives evidence of your experience.
Thank you. Linda.
Yeah, no, I would absolutely agree with the point that both Chloe and Nasreen have made about kind of networking and taking those informal opportunities and shadowing opportunities. I think that's really important. But I was also struck by at the point that came out of the survey, you know, the responses where people say, no, we've not got enough time, or we need more funding. And I think that's the trouble, isn't it? That can always feel like the thing that's going to get in the way. So I think there's something about how this is framed as well, in that, you know, often when we're when people are becoming more public health focused in their role, it's not necessarily about doing something additional, is it? It's about a way of thinking and a way of approaching the work that they're doing anyway. So I think there's something about how we can get that framing right, so people see this as a way of doing their job rather than an extra job to do, and obviously the support to enable people to do that.
So I think I'm gonna say two things. I think firstly, I'd say pay it forward. One of the things we hear is about how hard people have had to do to drag themselves between those layers and between those different chasms. So if you've been in that as a person on this call, chuck the ladder down, don't pull it up, right? And I think that's really important, because we often get to the next stage and then forget that there's like another 100 people behind us desperate to get to the place we've got to. So pay it forward as an individual, but also pay it forward if you're an employer. I really genuinely believe this, that, you know, investing in your staff is a really important thing to do. They are the only asset you often have in organisations, particularly public sector ones. And it's easy to make a short-term decision that has a long-term negative effect. But there's loads of evidence that if you look after your staff, they do much, much more for you, and they're much better. And, you know, I really believe in that. So I think there's something about, let's pay it forward. If you've been a recipient of something positive, you know, we've heard from all three people so far that they have, pay that forward. And I know all three of you do that, and do that in spades. I think the second thing I'd say is like, and I liked the point earlier about use what's out there. I'm going to shamelessly plug what we do, but there are other great products out there as well. I will shamelessly plug something that Linda has, is in All Our Health, which is an amazing resource, entirely free. You can go for that. But you know what? You know, our membership it is affordable, and it has an amazing array of things that come with it, not just access to webinars, not just access to our journals, not just access to some of our free training offer, which is available, our learning management service, getting in touch with other members. But also some of the stuff we've done around, you know, post-nominal letters, which actually allow you to be recognised as somebody in public health. You know, there are some brilliant resources out there, and we have to make better use of them. So there are a lot of things out there. You know, most of the stuff we do isn't that expensive, and actually employers for a very small amount of money could do something really good and positive for their staff with it. So I think, you know, we have to be quite honest about that, you know, if you've got a great product out there, we should be using it. And I loved all the stuff people have said about the networks that do exist. And just finally a plug, because I know Chloe mentioned about mentors. I know I've seen Jessica from the UKPHR is on here. One of the biggest challenges to getting people to use the specialist portfolio route is there aren't enough people who can support as assessors and mentors. And so if you're somebody on the register and you want to support somebody to have a career in public health, actually offering to help with that is a huge part of what's needed in the system once you've got yourself to that level. So yeah, loads of stuff I think we could do.
Yeah, thanks, William. So we've got about 5 minutes left for this session, and I wondered if each of the panelists wanted just to take a minute to either say something they haven't had a chance to say, or to reflect or kind of talk about one takeaway point from this panel. Chloe, I'll pick on you first.
Wasn't expecting that. I had to try and find the mute button. Reflection. I don't know what I was expecting from the conversation today, but it's been really invigorating, and I'm coming away from it really energized and quite inspired. I think I've got a lot more to learn about the wider public health workforce, and how in emergency planning there are probably groups of people and individuals we've not engaged with before and we could do. So yeah, I think I've got some homework to do after today, but thank you. I've learned things. Thank you.
Thanks, Chloe. Nasreen.
Yeah, I think for me, it's just been, I think we all kind of have that imposter syndrome. I have it in bucket loads. And I was like, oh, I don't know what I'll be able to contribute, but it's amazing how much actually you can contribute. So that's been lovely. And the fact that hopefully it's helped somebody or something that's been interesting. But yeah, it's just been a joy to listen to everybody. But also what I really love about public health is just the enthusiasm that people have, even though the budget's getting tighter, there's not enough work, you know, we're not really doing, I'm certainly not in the job that I, you know, aspire that's where I want to get to. But it's a journey, and what I think I've learned is just to take it one step at a time and just enjoy and get as much as I can from the bit that I'm in at the minute. So the work I'm doing now on stroke and doing the health needs assessment, I'm just absorbing and learning as much as I can so that I can be the best within the public health sphere that I can be. But just the enthusiasm, I think, from everybody else on the call has been great.
That's amazing and really moving. Thanks, Nasreen. And Linda.
Thank you. I think there's three things actually that Nasreen, William, and Chloe have said. So from William's point of view, I really kind of latched onto that that concept of the gaps in career progression, those kind of areas where you need to kind of do a big jump, and how can we fill those? I think that'll be really important. Chloe, you've made me think about kind of publications and whether we can be doing more publications to get this out there, and from Nasreen's point of view, just kind of reinforcing that networks and the importance of networking. Those are the three things for me.
Thanks, Linda. And William.
So I think you know, like I get to do this every day, all day. It's brilliant, right? I have the best job in the world, and that's partly because I get to work with really amazing, diverse, talented people, which I think we've absolutely seen in spades on today's webinar. If I leave the people on the call with one thing, please do have a look at the work we're doing around the wider public health workforce. If you are somebody in there and you want to be able to share your work with us, please get in touch. Indigo is going to share the details again in a minute. You know, the challenges we face, the problems we have, can all be solved, and can all be solved by doing some of the stuff we're doing. You know, the places that are most, you know, challenged are also the places where we could do more to develop the workforce, which are also the places that have the greater health inequalities, which are also the places where the greatest health benefit for them and our country can come from. So there is a huge opportunity here. We've just got to keep the faith and seize it, and please do work with us over the coming year on this work, because we can't do this alone. We need the rest of the system to work with us, because it's not just about what we do, it's about what we all do. But thank you very much for coming along and giving me a chance to speak.
Brilliant. Well, we've got a minute, so I'll just wrap things up. And Nazreen has just said, if you want to get in contact about joining her network, you can. I don't know how to cut and paste your email address into the network, Nazreen, but if people contact us, I can give them your contact details. So brilliant. Thanks so much for coming along to this webinar. I've learned a lot. It's going to be really helpful for writing up our report on all of this, which we'll be putting out in January. If people want to talk to us, and we really want to carry on having these discussions with the wider public health workforce, you can contact us at policy@rsph.org.uk. I'd encourage you to look at all of the various resources that we have on our website. We've got a career hub, we've got work around education pathways for the wider public health workforce. We do lots of qualifications, and we've got some space on there which captures all of this engagement work that we've been doing. But thank you ever so much. Thank you so much to all the panelists for coming along. You've been absolutely amazing and really inspiring, hopefully, for participants. So thank you. Goodbye.